Now, moving on to our first section, that is the capitellum fractures, which is one of the very common fractures, although it's a rare form, but when it occurs in adults, it can be highly devastating. We will be discussing in this section its clinical features, imaging, and its treatment, and why it's important to diagnose capitellum fracture, because once if missed or if not treated properly can lead to severe elbow arthritis, which can be very damaging. Now, coming to the fractures of the capitellum. It's a rare articular fracture that is usually most extensive than it initially appears, with involvement of trochlea and posterior humerus is common. As you know, the distal radius actually forms a joint with both the ulnar and radius at the elbow. It's a complex hinge type of joint. The trochlea of the distal humerus forms the joint with the ulna, and the capitellum forms the joint with the radius. Now, the problem is that this usually, when we are getting an AP and lateral view of the x-rays, sometimes very subtle fracture of the capitellum may be actually missed, and there may be a complex fracture which may have been displaced intra-articularly because it gets displaced into the joint, but still it can be even missed at times. So it's very important to view the x-rays around the elbow, especially the AP as well as the lateral view, because the lateral view is going to exactly tell you what is actually happening with the articulation between the capitellum and the radius. Now, coming to the clinical features, usually it's typically the elbow is held around 70 degrees of flexion. If you see this x-ray, this is classically lateral view. This is the outline of the olecranon, which is forming with the ulna, looks okay. This is the outline of the radius, which looks normal, but if you see the distal humeral line, anterior humeral line is coming down, but it gets disrupted over here, and then this is what is actually there. This moon-shaped structure is actually the capitellum fracture. Now, this could say with this, sometimes it could be so much displaced and rotated, but sometimes it could be so subtle that you have to very clearly visualize the lateral view, especially the lateral view of the elbow. Why it is kept, the patient usually keeps the joint around in 70 degree flexion, because this is the most relaxed position of the joint capsule. This was it only not only accommodates hematoma, but it is also patients relatively pain free. Mostly as it's on the lateral side, so there is swelling of the elbow. Sometimes it's lateral, but sometimes the whole of the elbow is swelling depending upon how much hematoma is formed, and you cannot really appreciate whether it's lateral side swelling or medial side swelling. But lateral side tenderness, especially with the radial head, is very common, and it must be evaluated properly, especially if there is tenderness, swelling, and patient is unable to move his or her elbow joint properly. Now, coming to the imaging. In orthopedic, the first and foremost are always the x-rays and always the two views, the AP and the lateral view. You have to get elbows AP view as well as the lateral view. Why we need to get an AP and lateral view? Because not only the AP view is going to tell about the general structures, especially the distal humerus, radius, and ulna, and their alignment to each other. Plus, sometimes there is associated fracture as well, which can also be ruled out. And on the lateral view, we need to clearly look at the anterior humeral line, which is coming right from here, and it has to go in through the anterior 2/3 of the capitellum. But if it is on the lateral view, it's not going. This means either the humerus line is disrupted or this capitellum is disrupted. And in this, if you can appreciate that if you draw an imaginary line from anterior humeral line like this, it's not going through the capitellum, rather the capitellum is lying right over here. So this is denoting the most likely there is a capitellum fracture. Especially in the lateral x-ray view, as I told you, we can appreciate the displaced capitellum. The radial head will no longer be congruently, and it will not articulate with the capitellum congruently. The capitellum may be rotated through a 90 degree almost to sometimes it may be facing the opposite side, that is the shoulder. Double arc sign is sometimes visible because sometimes its capitellum is fractured in such a way that it represents a double arc sign. And usually most unstable situation is then isolated fracture. Sometimes what happens is the problem is that it is associated with complex fracture dislocation. There may be other fractures as well, and capitellum fracture may not be initially seen properly. Isolated are relatively easily picked, but sometimes associated injuries, when capitellum fracture is associated with other fractures, they can be easily missed most of the time. Now, once we have done the X-rays and we're still sure about it, why we need to get a CT? The CT is actually for the proper planning of the surgery. Depending upon how much degree of comminution, if on X-ray there is a comminuted fracture, then probably we would like to go for CT so that we can properly plan whether we need to pin the fragments, we need to screw them, we need to put a plate around them, what to do about it. So CT scans are helpful in clarifying one thing, that is the diagnosis and extent of injury, because otherwise we will not be properly planned for surgery. There's a Bryan and Morey classification which divides it into 3 subtypes. This is the type 1, in which there's a whole bony involvement, there's a full fragment there. Type 2, there is only cartilaginous avulsion, almost a cartilage over the capitulum gets avulsed, and actually with a very small osseous part. This is termed as type 2. Type 3 is highly comminuted fracture of this. This was actually Bryan-Morey classification was modified McKee, which is added a type 4 injury as well, in which there is a coronal shear fracture of the capitulum involving all the way through the trochlea. This makes it type 4, but that is usually rare unless specific force mechanisms on elbow during the injury are such that it is actually displacing the elbow in that direction. As I told you, type 1 is mainly the complete simple fracture, type 2 is cartilaginous shell, and type 3 is highly a comminuted one. Now coming to the treatment. The way classification works is actually it's easy to treat a patient when we have classified the injury, and that is why the treatment starts with based on what type of injury it is. If it's undisplaced, that is most likely it's type 1, or it's less than 2 mm displaced, then it's rare. But if it is there, then probably it can be treated with a sling and analgesia. All you need to do is to give painkillers, immobilize the elbow joint for 2 to 3 weeks, and give it the elbow rest, let the tissues heal over there, and probably collar and cuff would be more than enough. But usually it's very rare that it's either an undisplaced or it's less than 2 mm displacement is there. Most of the capitulum fracture are displaced more than 2 mm. Now if they are displaced more than 2 mm, which means most likely it's going to be a type 2 or 3 injury, that means what happens is this reduced and held back. That is, even if we are planning for surgery, ideal is to close reduction of these fracture fragments. Close reduction if is feasible, and initially the close reduction must be attempted even if your planning is to go for open reduction and turn-off fixation. Then if after close reduction we assess it on the x-rays, if the fracture fragments become undisplaced and now less than 2 mm displaced, then probably we can go for, that is, we have converted type 2 and 3 into type 1. If that is the situation, we can go for conservative measurement in form of slings and analgesics. But if the fragments have not reduced, or there still are a lot of comminuted fractures present which are displaced, then probably we'll have to go for open reduction and turn-off fixation, which is more preferred in case of type 2, 3 and 4 injuries. Now coming to the fragments, usually when on x-rays they appear to be small, but they're always larger, and K-wires and headlock screws and plates can be done, which usually when we see it on x-ray, it looks like very small fragments, but screws can be inserted, especially the headlock screws, to the capitulum. Now treatment varies. Once we've decided that probably we're going to go open reduction and internal fixation, then how we can fix internally, there are multiple options. There could be as simple as if K-wires. If there is no dorsal combination, we can go for headless screws or K-wires, especially this is, if you can see it over here, this is called Herbert screw, and they have inserted some K-wires as well. Coming to which can be passed from anterior to posteriorly and to stabilize the fragment. But if there is a dorsal combination, then we have two options. One is to use a dorsolateral plate, in which we can just buttress the fragments and keep it over there till they heal, or even the partial fragment excision. Not whole of it, but partial fragment excision can be an option, but not always, because sometimes it works, sometimes it does not work. Once we have placed a dorsolateral plate, we may need to put a graft over there as well, so that the healing can be accelerated at times. Now, all these options are actually depending upon what type of injury it is. If it is 2 or 3 type injury, sometimes screws can be done or K-wires can be done, but sometimes comminution is so much that we just have to put a plate over there in form of a buttressing plate and come out, because even the extent of injury is so much that despite the maximum efforts, some degree of arthritis will be developing later on, and which could be very nuisance for the patient at times. If it's highly comminuted, as I told you, they have to be excised types, but not all the fragments are excised, because that produces elbow instability. But most of the fracture fragments which are actually cannot be salvaged are usually excised, and some are actually pinned back in form with screws and K-wires. If there is long-term outcome, usually may be compromised because elbow instability is compromised. Some degree of arthritis does develop in these patients, and which may lead to stiffness, non-union, and instability most of the time. Now, what's important over here is that in the injury to when we are opening up, for example, this is the surgery we're doing, and we're doing open reduction and tunnel fixation of these fragments, we need to make it sure that we repair the lateral ulnar collateral ligament properly, because the injury to lateral ulnar collateral ligament will result in instability later on during the elbow motion. In this section, we have briefly gone through what are the fractures around the capitellum. Capitellum fractures may be isolated or usually associated with other fractures. Mainly, they're classified by Brian and Moore into 3 subtypes, that is undisplaced, minimally displaced, less than 2 mm, or sometimes the displacement is simply a small cartilage shell is actually disrupted with small osseous part, or type 3 is actually highly comminuted fracture. This classification was modified by McKee, adding a type 4 injury, which was a coronal shear fracture of the capitellum. Now, this is mechanism is such that most of the time we have to go for open reduction and tunnel fixation. But we can attempt a closed reduction and see if it's type 1 injury, we can go for cuff and collar sling and immobilization of the elbow joint along with analgesics. But if it's type 2 or 3 injury and displaced, then we probably have to either go for headless screws, we can fix it form of K-wires, or we can use a dorsolateral plate as well. Sometimes even the fragment excision has to be done as well, but if it's highly comminuted fracture fragment. Thank you very much. Keep watching sqadia.com.